Good afternoon. On behalf of the session moderators, Mircea, Carmen, and myself, I would also like to welcome everyone on site and those who have joined online to this plenary on One Health. The One Health concept acknowledges that the health of human, domestic, and wild animals and the environment are closely linked, and that an integrated multidisciplinary approach is necessary to address health challenges comprehensively. Priority One Health topics include emerging infectious diseases, zoonotic diseases, food safety, and antimicrobial resistance. The concept of One Health has gained prominence since the early 2000s, and then came a time when everyone was talking about it, but few knew exactly how to do it in practice. Now we are at a point where significant efforts have been launched at regional and global levels, and also increasingly at national and local levels. Discussions around One Health should go beyond the scientific community. Collaboration needs to involve policy and decision makers, NGOs, local communities, industrial R&D across the globe. In this session, our speakers will address One Health advances and challenges at the EU level, present examples of community-level collaboration and behavioral research relating to One Health in Africa, and we will also hear about One Health from a global socio-political perspective and learn about innovative solutions to tackle antimicrobial resistance. So again, thank you for joining us. And now I give the floor to Mircea, who will introduce our distinguished speakers.
Thank you. A difficult subject of great interest for the present, for the past, and for the future. We are blessed to have as speakers for personalities that will try during this plenary to help us get into most significant details of this issue with worldwide resonance. So, please allow me to introduce them in very short terms and very few words. Sandra Galina, Director General for Health and Food Safety, a very important position and person. We hope that she will do everything needed in order to come and to be together with us in a remote way, because she's not here now. Steph Bronzoir, Research Coordinator at the European Food Safety and Health Authority. Different important subjects for cooperation, scientific cooperation, for antimicrobial resistance, for research and communicable diseases, and food safety. Karen Sailors, CEO and co-founder of Labyrinth Global Health, performing studies that aim to understand and mitigate biological and behavioral risk of disease transmission. And Greg Martin, Director of Health Protection Surveillance Centre in Ireland, with an important background in global health. It is for sure worth seeing at least all the information that you can find available on ESCAIDE site, but also the multitude of other information regarding their prodigious activity. To note, the presentation will follow one after the other, and there will be a time for joint discussion at the end. So.
Thank you, Mircea. I hope you allow me to have again another Slido poll today, because we need to acknowledge that there is a big divergence between countries in terms of engagement and approach to One Health. So please use your app and connect, because we have a couple of questions for you before we start with the speakers. So our first question, we should have it soon reflected here, is what is in your level of, in your opinion, the level of practical implementation of One Health in your country? So please choose one of the options and we will see what we get. Results, intermediate, okay, that's good. 35%, basic 29%, advanced 15% only, and pioneering 6%. That's promising. Okay, should we launch then the next question? So that's a bit more personal. And it means, how do you see yourself regarding One Health? Have you been working during the last 12 months in One Health? So the options are regularly as part of your work. The second is fairly regularly, a little, or not at all. This should be quite an easy one to respond. Results. Okay, so here is quite balanced, but a little is 34%, not at all 31%, and regularly as part of your work 22%, and fairly regularly 14%. Okay, I think that, well, there is still a space for improvement, but we have a reasonably good situation. Thank you very much. And yes, with that, maybe I would pass the floor to you, Agnes.
Thank you.
I think we have her. Try.
Okay, so let's try to see whether Sandra can connect. If she can connect, I invite Sandra Gallina, Director General for Health and Food Safety at the European Commission, to talk about the political and policy context of One Health in the EU and globally.
I am long connected, but I don't know if you can see me. Yeah, I think you can see me now. I've been long connected, so don't despair. I was there, and I like the Slidos. So I think that the first point where I would like to start is, first of all, to thank the organizers of this meeting. We need more of these meetings because many of these issues are, I would say, somehow in the realm of a few experts, and you will understand why I'm mentioning the issue of the expertise and the silos, because this is one of my, I would say, hobby horses. So first of all, many thanks to bring us all together. We have been in DG Santa dealing with One Health for, I would say, many years. Perhaps we were not so conscious that this was One Health, or at least the issue started to acquire a life of its own and grew legs quite recently. But at the same time, you know, this is something that we have always been doing. The example that we have most of the time is that of antimicrobial resistance, because, you know, we have had a lot of work there in the past. And we have recently adopted at record speed a council recommendation, and the speed comes from the council, meaning that the member states have approved this recommendation in no time. And this is quite impressive because the member states were imposing on them quite a few commitments here. One of the commitments I want to mention is the reduction of sales for antimicrobials for, I would say, animals by 50%. We have had a long discussion on the calculation of the sales number in the TAFTAR meeting recently. And then we have a real stark 20% reduction for consumption of antibiotics in humans. So as you can see, we're trying to tackle the two angles with this recommendation. The recommendation contained many other things, including big communication, because one of the soaring spots is really communication. So as I said, it's a very ambitious recommendation. Why is it ambitious? It's ambitious because we need to be ambitious, given that perhaps in 10 years' time, 9 out of 10 of the infections will perhaps be multi-resistant. So I say it's in our interest to start thinking about this. In 2035, according to what we have been reading, it might be even more dangerous to be in a hospital than outside the hospital, because you may acquire one of these nosocomial infections that you can't tackle. Now, I think that therefore it's important to say AMR is a public health emergency, but it's also an economic emergency. There are numbers, and I'm very grateful to the OECD for all the numbers that they produce. There was a recent report where they were saying that if every European country could spend €1, I would say we would have a lot of returns. They were going for dollars in terms of returns, but then, you know, there was a much more specific calculation where they said with 3.4 euros, you would, and this is a mix of things, so there is hospital, community-based AMR interventions. With that type of investment per capita, we would be able to avoid a calculation, you know, very ballpark figure, 10,000 deaths, 600,000 new infections. We can avoid also, I would say, to spend 2.5 billion in health systems. So let me say, going back to the €1, I say €1 invested, €3 economic benefits, more or less. At OECD, so beyond the EU, the ratio is even bigger, and we have €1 for, I would say, 5 gained. Now, there isn't one only recipe that we need to use. The problem is exactly this, that we need a panoply of measures. And when there is a panoply of measures, you need to be aware that we need to be much more integrated. The recommendation includes measures that have been flagged as determinant at a very good event that we had in Luxembourg, the One Health Conference on the 13th of November. So, for instance, these determinants were surveillance, integrated surveillance. I hasten to add this integrated surveillance, and then, you know, training for professionals on One Health approach. There are some AMR champions. How can I forget them? These champions should be the ones that go around trying to project the importance of AMR. They should be figures, heroes, people that are very well known. If we want to really, I would say the best would be to have a celebrity to go around. I was told that Madonna had a big infection, so perhaps she could be one of these ambassadors for AMR. Let me say to you, we need these people to counter disinformation. We are doing all we can, but AMR is a topic that polarizes views. It's not an easy topic. Now, the COVID-19, unfortunately, we needed the COVID-19, accelerated the whole process and, in a sense, put the One Health in the spotlight. Now, we had to reinforce our health security framework. Under the European Health Union, we have been revisiting the cross-border health threats regulation. But we also have an impact across the sectors, across the disciplines, to prepare, to detect, to respond, I would say, to the emerging diseases. So, you know, there are many vector-borne diseases and zoonoses that somehow have become more important for us in this drive towards detection, early detection, preparedness. Now, the regulation on cross-border health threats that I just mentioned is trying to give a better capacity for also accurate risk assessment. Now, we need to promote a more coordinated response. This is what in this legislation we have tried to ensure. Also, with third countries, not just within the EU, with the agencies. I'm very, very grateful to all my agencies with whom I work, and we work for each other and with each other. So many, many thanks to Andrea and all her teams, because, you know, we would not be at this meeting even thinking of what we're doing without ECDC. So we have, at the end of the day, to develop an EU prevention, preparedness and response plan. It's a huge responsibility. Now, the member states need to develop their own national plans, and I tend to insist that the European plan is not a collation of national plans. It needs to be something else. It's something which is a very important element. If it needs to function, it needs to be something which has its European value. Now, we have an important aspect in this new legislation, which is the possibility to declare the public health emergency at EU level. So we don't want to be in contrast with WHO, but let me say, waiting for months that the pandemic was declared was far from ideal. So we now want to be able to declare it ourselves. And with that, there is a whole set of measures that are triggered, you know, from availability of critical medicines, coordinating the different measures, and so on and so forth. I don't want to be too long on the long list of issues but it's important that there is in all this set of actions the activation of the support from the ECDC to mobilize the EU Health Task Force, which is an important achievement in this new legislation. I hope that something will be said at this ESCAIDA meeting on this task force. I'm very proud that we achieved that. Now, still on the One Health approach, I would like to say that the scope of public health risk assessments will be broadened, so that we can support all hazards, an all hazards approach. We have been discussing this long also in the latest senior level Health and Security Committee in Luxembourg. So depending on the health threat, one or several EU agencies may contribute to the risk assessment. And this is a very, very important element. I know it's also an important element to try to decide how we work for this risk assessment with all the agencies. Now, the Health and Security Committee I have just mentioned is a coordinating body in the EU. Its role, it has been strengthened, further strengthened. It has further responsibilities because it adopts and it guides the opinions to support the countries, the member states in prevention, in control. We have already had a recent experience last year at Christmas. I hope not to repeat it this Christmas, but it was to try to coordinate the measures at airports because of the Chinese outbreak, you know. Let me say, it was a fantastic experience and very successful. We proved to me that the HSC can be activated in no time. Within the HSC, I must say, I'm also very proud that we succeeded in having joint work of the chief veterinary officers and the Health Security Committee, so CVOs and CMOs. It is a committee that has been meeting at technical level throughout summer because of the avian flu. I'm very proud to see the work that has been done and the way that we have been trying to be, I would say, really active in living, in embodying the One Health principle. Let me say, it's extremely important that trust and rapidity of communication is there, and this can only be there if you have, I would say, channels that are used regularly and that are not invented at the moment when there is the crisis. Now, we need to count, as I said, on the scientific assessment of the many agencies, EFSA, ECDC, EMA. They already have a cross-agency task force, and I am very happy to have in this panel Steph Bronsvar from EFSA, who will tell you more about this task force. In Luxembourg, we have Carlos Neves, who also was very active in trying to explain the good work that this task force is doing. Now, at EU level, we have perhaps very strong animal and human early warning systems. Now, data, however, are not yet integrated, and this is a priority for the work plan of 2024. I give you a practical example. On the 12th of October, we organized, as DG Sante, a simulation exercise on avian flu. So what we wanted to test is the communication, the response across the different Commission services, but also involving ECDC, EFSA, EMA. We noted during the exercise that the experience, gained during the pandemic helped us organize the communication and the response between the various directors, the various agencies, the various sectors. But the exercise also highlighted that sometimes the roles need to be better clarified. So there's work to be done there. As a follow-up, we think that in 2024, DG Sante will organize a One Health simulation exercise with the EU and EAA countries, inviting environment, animal, and public health authorities. So fasten your seatbelts because we want to test the things before we need to use them. This leads me to mention to you the global agenda. The global agenda is equally important because we are only safe, or we are as safe, I would say personally, as the weakest link in the global network. So we need to achieve a successful implementation of the One Health approach, and we as Europe are convinced that this can only be done through sustained political commitment. It cannot be that One Health is implemented by technical services. There needs to be a political will behind it. The WHO has been urging investing in One Health. It has also put out, like I was doing earlier, the economic benefits. The World Bank has made many estimates. For instance, they say that work in One Health could be giving or bringing back $37 billion per year to the global community when you invest 1/10 of this amount. So, let me say to you, there is a big scaling up of the effort when we do it. We have been, as European Union, promoting the One Health approach in international cooperation, but also in the multilateral fora. In UNGA, we had meetings in UNGA, we had in the WHO, in the G7, in the G20. The global health strategy is based on the One Health approach. And in the ongoing negotiations of the pandemic agreement, we want the One Health approach to be really enshrined in the treaty. Now, in the context of that negotiation for the pandemic agreement, I would like to say that we would like to promote immediate action on the ground to close the gaps across the whole spectrum of prevention, preparedness, and response with a One Health approach. And so we have plugged in many of the actions that we have in the global health strategy. So there are the two parts: what we do in the law, in the international law, but also what we're ready to do at international level with the global health strategy and with Team Europe. Now, we hope that our engagement is visible. In any case, Europe is walking the talk. We walk the talk because we are, with a MAV Plus initiative, we are promoting regional and local manufacturing hubs for vaccines, but even beyond vaccines. We have invested in Africa and for Africa, 1.2 billion. This is, I would say, the part of money that comes from the Commission, but there is this is a Team Europe initiative, so there is much more money from the member states, and we will be expanding to South America and to Asia. It's extremely important that you bear in mind that we are not just talking, but we are also doing what it needs to be done. Voluntary technology transfer to empower our partners is there if they so wish. Now, we need to somehow coordinate also all the streams that exist of money that exist at regional and at international level. For instance, like the pandemic fund. It is extremely important that we do not have duplications of funds that repeat financing for the same measures, but that we try to finance in a more appropriate way the measures that are necessary. I thank you for your attention. I wish I were there, if only because I saw some sun there, whilst here, it's still not very nice weather, but let me say, better than the other days when we were drenched and soaked. So thank you, and really thank you for organizing this session on this very momentous topic. And I want to say to you that at the TAFTA, we have decided with Dame Sally Davies that we will no longer use this silly label of the silent pandemic. Is nothing but silent. It's a grand pandemic, the AMR. It's a grand pandemic because on the one hand, we will have fewer supply, and on the other, we are having more infections that are resistant. So I don't see anything silent in that. Thank you to you all, and I can remain for a few minutes for questions, or for one question at least. Thank you.
Thank you so much, Sandra. I think we have time for one very short question and answer. In your opinion, what is the top priority step we need to take? Just, like one sentence.
Oh, no mic.
Okay.
I think we are losing the audio.
Yeah.
I don't know.
Sorry, here it is. Is it working? Is it working?
Now you're on. Yeah,
Yeah,
please.
thank you. So it's a very cruel question, because you can imagine that this is like Sophie's choice. You need to choose between different things and all of them being very important. But if I were to go by experience, I think that the only thing I would suggest is that we need to be more polluted. And this people find very strange when I say it. We need to expand the recognition of the concept of One Health to other disciplines. We need to include the social sciences. We need to have a coordinated approach that breaks down the silos, opens up discussions across the sectors, reduces the blame game. I mean, in a sense, what I am dreaming, and I said it also in the One Health conference, you know, the approach that we took in the 17th or 18th century to be more and more specialized with science is very effective. It's very useful. I'm not denying that. But we need to go back to a more to an approach which is more reminiscent of the Renaissance. We need to be more universal. One Health does not exist per se. One Health exists because of a convergence of issues. And, you know, it's very difficult to seize the concept if you really work only in your silo. And I would like to say that while DG Sante is the embodiment of One Health, I can tell you that one of the actions I was most proud of very practically this summer was the meetings that we were having between our veterinaries and the public health authorities. This was not simple to organize. This was not simple because, let me say, we enter into a long tradition of relationships that are of a certain type. We don't want to go there because we want to be motherhood and apple pie here. We don't want to go into the nasty parts, but the added value of having the two sides of the equation in the same room, discussing the economic side of, let me say, the breeding of animals, together with the public health measures and the cost of not taking some measures on animals and the risk. I mean, this is fantastic. It may be difficult, but this is why I say we need to have a more hybrid approach. We need to consider the difficulty that there is in creating this action that stems from problems in one side that affect another side, and therefore the first side needs to take the measures. I think that the only risk I can see is that by dint of then creating this new way of working, we might create another silo in itself. So I sincerely hope that we will be able to develop soon indicators to monitor the implementation and to evaluate also the One Health approach so that we can collect relevant data. Not an easy task, but I think that if we go there collectively, we can succeed.
Thank you so much for these lovely closing words. I think we need to move on in the interest of time, but we really so much appreciate your presence and interest. Thank you.
Thank you, thank you.
Thank you very much. And actually, along those lines of collaboration between sectors and between agencies, I would like to invite you, Steph, to present the work of the cross-agency task force.
Good afternoon. Great to be here. Thank you for the invitation to be here as EFSA, the European Food Safety Authority, currently chairing the cross-agency task force on One Health, which brings together, in fact, ECDC, EFSA, the European Environmental Agency, EAA, the Chemicals Agency in Helsinki, and the Medicines Agency in Amsterdam. Compliments also to Sandra Galina and her team for organizing a great conference last week in Luxembourg, as you referred to. I think it's important to take up, and you did take up, this leadership role on One Health, because the journey will be long and challenging, so it's important that we have a push from your side, and you did so magnificently. So thank you. One Health, European Food Safety Authority. If you remember, in the 90s, we faced a number of food scares, the mad cow disease, many of you will remember, which, if you think about it, is an issue that started in the feed chain by feeding bone and meat and neural tissues from cows to other cows, which led to a disease among cows, the bovine spongiform encephalitis, which in turn then led to the variant Creutzfeldt-Jakob disease in men, in humans. So a real One Health problem. So EFSA was actually created in the wake of the mad cow disease and the number of food crises in the 90s. And not surprisingly, by its founding regulation, the General Food Law, in the mission statement of EFSA, actually you see what is very close to a One Health definition. At the time, One Health definition did not exist. If you read that we're set up to protect human life, animal health and welfare, plant health and the environment, you see that why One Health is really close to EFSA's heart. Interestingly, actually, not only EFSA was set up in the wake of a crisis, but actually also ECDC, following the SARS-CoV in 2003. And now more recently, following the COVID pandemic, also HERA. So it's an example of how crises can lead to change. And maybe that is what we need now also with One Health. We need a change. We need to recognize that we have urgencies to address. In EFSA, we're working since the beginning because of our mission statement on One Health. We have a robust team working on biological hazards, foodborne outbreaks, zoonosis. We produce One Health zoonosis reports since many years. But we felt it's important to start asking the question, what does it mean to operationalize One Health throughout EFSA? Also in other areas, not working so much on biological hazard. So we reached out to our colleagues, we organized a survey, trying to identify the gaps, the barriers that people face in implementing One Health, and also the needs. At the same time, also asking for good practice, because in fact, we should not forget that a lot already is happening. I was interested by the answer a little, which the question at the beginning, if we were working on One Health. If you take it actually from the side that we all work on public health, actually you can argue that we all work already on One Health. Much more is needed, indeed. So we did the survey. We have set up also an internal task force to deal with the operationalization of One Health. And now in December, we will speak to our management board on what the next steps can be for EFSA to operationalize One Health further throughout the organization. Of course, One Health that we do in EFSA, we do not in isolation. Since the beginning, we have cooperated with ECDC. You will remember that actually ECDC incorporated a number of disease surveillance networks, among which the EARS network, very dear to my heart, that measures antimicrobial resistance in humans. EFSA, from the beginning, monitors antimicrobial resistance in food-producing animals, and EMA actually monitors antibiotic consumption. So over time, these data have been brought together also in a joint reporting, which is now known as the JACRA report, which some of you will know probably. So on our 20th birthday as EFSA last year, we convened the so-called ONE conference, One Health Environment Society conference, together with the sister agencies. Because in fact, we know that we are facing a number of grand challenges like climate change, the impact on infectious diseases, on food safety. For example, we know that we need a transition to sustainable food production. And obviously EFSA is very keen that this transition can be a safe transition. So to answer these multi-sector questions, we feel it was important to bring together multi-sectoral people. So we worked together with our sister agencies, as we call them, to develop this program. And the outcome of the conference basically is that we need a One Health approach, more than we have today. One of the sessions, actually moderated by Mike Catchpole, was to look into research coordination and bridging research and policy. Because obviously EFSA, ECDC and the agencies are knowledge centers. We're often knowledge brokers between science, bringing together science into scientific advice for the policymakers. And there we maybe can do more to work together, again, towards a One Health approach. And we feel that over the years, increasingly the agencies have tried to formulate also the research needs, so to translate the knowledge gap that they identify in providing scientific advice into research needs, which can also inform research agendas. And there we think now it's the time really that we work together also across the agencies to inform about transdisciplinary, about One Health research needs. And there, in fact, that was counted also by contribution from the European Parliament in that discussion, making the case, rightfully I believe, that EU agencies actually are well placed also to inform research agendas. For example, because they have a large network of networks that they organize in the member state. They have a lot of expertise in the agencies themselves. And often they also work on research questions that come from scientists. So therefore, it's important that also the agencies take up an active role in research programming. And another outcome of the conference, an important one, was, in fact, a commitment from all the sister agencies to come together in what we call now the cross-agency task force on One Health. In the meantime, interestingly, also the European Parliament obviously looked at the lessons learned from COVID and has come forward with a resolution which not only calls for the EU to integrate One Health in its different public health policies, but actually also underlines this role to promote scientific research across the different scientific disciplines. And interestingly, they also call for this cross-agency task force on One Health, which by now has been established. Indeed, we started meeting this year. In fact, in June, we published the objectives of our cross-agency task force. It's kind of the terms of reference that you can find, if you have good eyes, on the link that is on the top of the slide. And we agreed there to work together mostly around 4 priorities: strategic coordination, research coordination, stakeholder engagement, and joint activities. For the strategic coordination, obviously we need to be clear and set priorities because resources are limited, finite, so we need to be clear what delivers the best value for the buck. So where do we put our resources into together? Research coordination, we believe, is an important one. As I said before, we have a role as agencies to play in translating knowledge gaps, research needs into the research agendas. And there we will engage actively with the research agenda setters. Stakeholder engagement, like Mike put it nicely once, it's important to have a common doorbell. If people want to reach us as agencies, they know where to go. So that's an important function. And also, obviously, all of our agencies interact with a great deal of stakeholders, many of whom overlap. So it's an important, tangible sign also of work cooperation that there now is this cross-agency task force. And finally, the joint activities, we are starting up to work up these work priorities into a work plan to see what we can do concretely in the next coming years in a stepwise approach, probably piloting a number of issues as long as where we can find and identify resources and ideally bring in additional resources from funding schemes, external funding schemes. One example which is already in place actually is the Commission has asked the 5 agencies plus JRC to work together on azole fungicide resistance. It's an important health issue, obviously. As you know, Aspergillus infection is a very debilitating fungus infection affecting humans. And it turns out that actually not all the humans that show resistance to azole actually have been exposed before as a therapy, but probably may have been exposed through environmental means. So now actually the agencies are working together to quantify, to understand these environmental contribution to be able to address the question from a holistic, integrated perspective. And then finally, on the occasion of last week's One Health conference organized by DG Santé, as a cross-agency task force, we also came with a joint statement signed off by the 5 executive directors, where we brought forward 4 priorities. First of all, the research coordination, which I already explained a little on why we're interested in that and why we can contribute. Then we think it may be appropriate, in fact, to invest R&I in the future, for example, under the Framework 10, because there will be a lot of knowledge gaps to cover to be able to practice and operationalize One Health. Secondly, mainstreaming One Health through the different scientific disciplines. The cross-border health threats regulation already was mentioned as a way that could be, as a tool that could be, in fact, bringing the scientific advice together from the different agencies, and that we all want to contribute as agencies in supporting the Commission. Thirdly, important that we are working together on the governance. So, for example, we have good experience as Europe with the intersectoral mechanisms on AMR over the past decade. So why not use that as a model also to broaden that aspect for One Health? Important also there, the integrated surveillance already alluded to earlier. And finally, but importantly, capacity building. We have a lot of knowledge to gain across the different scientific disciplines. And there, the quadripartite has made a good push on what further capacity building is needed, and that we would want to support and welcome by the different agencies. So with this statement, we believe that we as agencies are very clear that we are keen and ready to work with the Commission on One Health. Thank you for your attention.
Thank you very much, Steph. Perhaps we still have time for a question, and that would be similar to the previous. If you have so much already planned in your plate, what is your priority for 2024?
I think I would argue very much along the lines of Director General Galina. Be ambassadors for One Health where you are. One of the challenges with One Health is so broad and encompassing that it could lead to paralysis. And we shouldn't be paralyzed, because already today we do a lot together, and individually we can see where we are to look across these silos that were mentioned. Maybe more than breaking the silos, we need to make sure that we connect the silos. And there I think One Health really comes in to use the knowledge that comes out of these silos and bringing it together from a One Health perspective. So I believe everybody can be an ambassador to look outside the box.
Thank you. Please.
Yes, thank you very much. So now it's my time to invite Karen to talk about her experience on One Health in the global context with a focus on societal issues and their attempts to broaden One Health capacities in universities across Africa. Thank you.
Thank you. Hello, everyone. Can't see you out there, but it's really a pleasure to be with you today. I want to thank the organizers for inviting me to talk a bit about our experience as a US-supported project, and really a 15-year initiative, I'd say, to focus on One Health issues across Africa and Southeast Asia. So, about 15 years ago, there was a USAID, which is the Agency for International Development, Emerging Pandemic Threats Initiative in Washington to really catalyze integrated surveillance across Africa, Latin America, and Southeast Asia. I was very much focused on Africa and Southeast Asia, and really what we were attempting to do was to work with ministries of health, environment, animal health, and wildlife health, forestry, and fauna, and try to collaborate. It was a cooperative agreement, so not really grants, but really a cooperative engagement with the countries to try to work together to co-locate surveillance really in from an epi perspective at the same place and the same time, to be able to recognize at a very early stage potential zoonotic viruses emerging in wild animals and with risk for spillover into human populations. So based on the literature, we really focused on 3 taxa, bats, rodents, and non-human primates as our main focus. Though in the first early phases, we sampled very, very widely, had a lot of civets, a lot of just wild animals that were collected through engagement with hunters, with a lot of capture and release of wild birds. So we're really looking at those moments of viral shedding, and at the same time, we thought more about it and said we really must try to work with humans when they're sick, right? So we started doing syndromic surveillance of people to detect those potentially zoonotic viruses that cause disease, and those usually, are detectable when a person is febrile. At the same time, I was really leading the effort to assess behavioral risk. I'm a medical anthropologist, and a big part of this initiative, which we added around the halfway point, 5 years in, was to really focus on those high-risk behaviors, really occupationally driven quite often, which are, social economic drivers for needing to expose yourself to wild animals. So we worked a lot with hunters. We worked in live animal markets, in what we call in Africa bushmeat markets, so really where hunted animals are brought, recently killed for sale for food. So this was a global initiative. We worked in 30 countries, and as my colleague yesterday in the last plenary talked about, we worked with Harvard Medical School to track this on Health Map. So this was very much an engagement at the country level, where data was very much submitted in real time to Health Map. We were, as I said, sampling animals, engaging with humans who were really at risk, we esteemed at the sort of zoonotic interface, and as well as, syndromically vulnerable people who were basically sampled, with their consent, of course, to really try to triangulate some of these emerging zoonoses. So this is just a snapshot of these data. This was an open access database, and they were also correlated with GenBank, so that samples, once they were tested at the national level, were sent for sequencing when we had presumptive positives. So those were all triangulated, and there were data sharing agreements across all the countries so that these would be available for public health and research purposes. So this was a challenging effort, as we've heard from all the speakers so far. This is not easy work. We are specialized disciplines quite often, and it's hard to get out of the silo. But the purpose of this was really to work together, and has continued in some interesting ways. We found that there was a real need to reinforce the workforce, because there were not many people who were experienced in some of the places we worked in sampling wild animals. So there was quite a bit of lift at the laboratory level, at the field level, to really reinforce the country capacity so that they would be ready in the prevention, detection, and response phases when an epidemic or pandemic came along, which we were certain would happen. There were some research successes. We discovered some important bat viruses, a new Ebola virus, Bombali, in Sierra Leone. Marburg virus was found in bats, also in Sierra Leone, and a new Zaire Ebola virus, not new, but it was found in a bat as well. So this is something that really reinforced some of the suspicions of, bats being an important element in this transmission dynamic. So the important thing to me is, what then do you do with the information? And we were really very dedicated to the idea of trying to get the community's voice in this, to look at risk perception, reasons that people were doing what they're doing, so really getting at some of those socioeconomic drivers. So we did extensive key informant interviews, we did a lot of focus groups, and really community participatory engagement from the very beginning, to really make sure that there was a communication flow. When we found, in the beginning when we were developing the questionnaires and really deciding on our sites, we really engaged. And then when there were some of these viral discoveries, there was a real engagement to go back to the communities and talk about what this meant. We worked in DRC, just to give you an example, in 8 bushmeat markets, live animal markets that were integrated into local markets across Kinshasa. And we were really looking at subsistence hunting, that meat flowing into the urban environment. And there was, great movement. That is a city of, 13 to 20 million people. We're never really sure how many, but it's a huge city. And so the potential for spread would have been catastrophic. We really looked at exposure, risk perception, and we looked quite a lot at where meat was originating from. Some meat comes across from Republic of Congo, from up country, and there was a good bit of exchange and really understanding of some of the unknown factors that were really driving people's engagement, and thoughts about things to mitigate that risk, and an ongoing dialogue with that community about what that would look like. We really focused and continue to focus on key interfaces. This is from some live animal markets in Vietnam. We also collaborated, Labyrinth, my team, are an NGO based in the US, but we worked extensively in Southeast Asia and Africa. We worked with Wellcome Trust on a project early on to really look into some of those drivers and some of the risk behavior in markets. And we're really interested by the fact that there's a lot of cross-border movement of rodents from Cambodia into Vietnam for food. And so these rodent markets were something that we decided with that collaboration with Wellcome Trust and Predict to really focus on that field rat animal value chain, and really found a huge amount of coronaviruses in the trade, so cross-border trade, in the large markets, and in restaurants. So there was some important findings that really led us to be looking quite attentively at live animal markets, as we found turned out to be quite important for COVID-19. So the socioeconomic and behavioral risk factors are really an important piece of this dynamic, and we really have to look at local economies. We have to understand why people are doing the jobs they're doing. A lot of meat preferences are often quite cultural, traditional, and a lot of the reasons that people work as hunters or as bushmeat market workers in this picture in DRC are because there's no local option. So this is what people are sort of forced to do to gain their livelihood. But also we learned quite a bit about talking to some of these sellers, is there was a real dichotomy, I guess, between people's understanding of or perception of domestic animals versus wild animals. People said very freely that domestic animals are quite prone to making humans sick, so both in terms of food safety and in terms of disease spread. But there was a perception that wild animals are pure, that they live outside of the human realm, and therefore they weren't seen as risky. So you know, these were some things that we needed to really take into account as we came back with the risk communication and engagement messaging to really talk through what can people do to make sure that they don't put themselves at risk. As a carry-on to this project, there has been an important initiative, again, supported by USAID, which is focused on One Health capacity building. And it's called One Health Workforce Next Generation. So it's really focused on creating networks of university leaders and the ministry, along with a quadripartite engagement across Africa, with Africa CDC, across Southeast Asia, with all the stakeholders, to really figure out the ways of increasing that capacity in all the sectors. Because there is quite a bit of divide often between veterinary health and human clinical health. So really to try to figure out ways to bridge. And so there's been university engagement. This was in place and very active when COVID hit. And this is something that we've really been thinking through in terms of the way you get the community to engage. One of the things we did early on with PREDICT when we found some of those bat viruses that I talked about was to go back with this book called Living Safely with Bats to really emphasize the importance of bats on the environment and really thinking of bats as a way of pollinating protective factors that they contribute to our livelihood. The reason you have plants to eat and flowers around you is because they're there to pollinate, so that there was less of this fear reaction for just trying to kill the bats that are in the caves where people gather guano or hunt bats for food. So this has been something that we really have tried to identify our communication champions in those local communities, and also to really make sure that those messages are simple and straightforward. I really appreciated the session previously on the risk communication, community engagement, and just really thinking through what are the ways, for COVID in particular, what are the ways that we could really get in some resistant situations, such as in Côte d'Ivoire, there was huge resistance among faculty. And so some of the champions for, that the Ministry of Health put forward were actually not getting vaccinated themselves, and people found out about this, so they were unreliable narrators. And so some of those messages had to be reframed, and student groups, there were a series of student One Health innovation clubs that were really, really strong and effective in getting those messages across as social listeners, as really engaging with the communities to really figure out what were some of the pain points for vaccination. So with that, let me wrap up and say thank you very much.
Thank you, Karen. Just as a soundbite, what would be your top priority for the next 12 months, for example?
I think that as this community that I've seen here over the last couple of days, I think we're all aware that COVID was one in a series of emerging epidemics, hopefully not pandemics, but that we all have to work together and work towards this multi-sectoral engagement where we're all working together. For me, a really important part of that is the community engagement. And community can mean a local community. It can mean this community of organizations and associations that really work towards figuring out that bridge with risk communication and social listening, finding mechanisms for there to be feedback so that there is some political will to have these mechanisms in place ahead of the problem. So that's what I would say.
Is One Health's mission possible or impossible? So I would like to invite Greg to share insights into how the global social political environment has shaped our response to One Health challenges, and in particular in respect to with antimicrobial resistance. Thank you.
Thanks very much. Hello. So somewhere in the audience is my lovely wife. I've never spoken to an audience with her in the audience, so if I seem a little nervous, it's not the rest of you, it's actually her out there, because I'm not going to see you for a while, but her I will live with. So, and incidentally, today is our 10-year wedding anniversary.
Aww.
So thank you for that. And thank you, Anna. I still love you with all my heart. Right, antimicrobial resistance, it's a big problem, as we know. I think at the moment the estimate is that about 35,000 people in Europe die every year from AMR. Globally, we expect by 2050 there to be about 10 million deaths a year. So this is a substantial problem, and that we need to address and take very seriously, as has been pointed out this afternoon. The solution, of course, part of the solution is all of the preventative things that we've spoken about, more responsible prescribing and consumption patterns, less use of antibiotics in livestock farming, of course. But we know that behavioral change is difficult. We've seen that with climate change. We see that with AMR. And part of the solution is going to have to be, we need novel antimicrobials to be developed. That's going to have to be part of the solution, firstly. Secondly, part of the solution is going to have to be, we need to make sure that diagnostics and treatment is available in the poorest parts of the world. Because as was pointed out earlier, we're not safe until we're all safe. Okay, and that's an important part of what I want to talk about. So I want to talk about those two issues, novel antimicrobial development and access to medicines and diagnostics in the context of the socio-political environment that we've lived in over the last 30 years. And I'm going to divide it into a couple of seasons, shall we say. In the 1990s, I've called that the era of multilateralism. And I've said multilateralism with tea and cake, because I think it was a lovely decade. And then we move on to another era that I've called polarization like a punch in the gut. And things fell apart, and we'll talk about that in a second. And superimposed on this socio-political timeline, we went on some public health adventures. And I've called those thinking big, thinking smart, and outsourced thinking. And we'll talk about each of those one at a time. But let's first talk a little bit about the political and social environment in which we went on these global health ventures, particularly in the context of AMR, access to medicines, and the development of new drugs. And we'll start off by talking about multilateralism with tea and cake. I loved the 1990s, and I think it was a fantastic decade. I was young and healthy. I looked much better. I had hair on my head. It was terrific. But the 1990s really was a decade of fantastic multilateralism. The Berlin Wall had just come down. The Cold War came to an end. Nelson Mandela comes out of jail. Apartheid in South Africa comes to an end. And I was in South Africa. I'm a South African at the time, so I was very excited about that. We all go online. We get cell phones and internet email addresses. It's the quintessential decade of globalization. Economists talk about the long boom. They say there's going to be this endless economic growth and we're all going to be rich. Political scientists talk about the end of history. And by that they meant that because of economic integration and the spread of liberal democracy, they really believed that conflict between geopolitical rivals would just evaporate and go away. And they believed it. And this was genuinely the thinking at the time. But all of this led to a tremendous sense of multilateralism. And in the context of that, we did some very exciting things in the global health space. And I'm going to talk about that in just a second. But of course, this was followed by what I call polarization like a punch in the gut. I'm not going to go through all of the points there, but I do want to say, and this is not to make any value judgment on things like BRICS and Brexit and the Trump administration. But these things did happen either as a consequence or a function of a contributing factor to an increasingly polarized world. So BRICS, for example, that's it started off as an economic group of Brazil, Russia, India, China, and South Africa. And soon to that group, there'll be the UAE, Saudi Arabia, and Iran. It started as an economic club, really. It's now self-described as an economic, political, and ideological counterpart to the West. it's part of a polarizing world that we need to be thinking of and cognizant of. Brexit broke my heart. It's still too early to talk about, so we won't. The Trump administration, Donald Trump threatened to leave NATO, threatened to leave the WHO, did leave the Paris Agreement on climate change, did leave the Trans-Pacific Partnership Trade Agreement, and this just contributed to this increasingly polarized world. Of course, the financial crisis didn't help, and then there was COVID-19, of course. But let's start talking about public health, global health, and of course, antimicrobial resistance. And let's look back at a happier era, happier for me at least, and that is what I consider the global decade, the sort of global golden era for global health. During this 10-year period or an 8-year period, it spills over the 1990s because a lot of the exciting things that we see in 2003 started in the 1990s. In this era of massive multilateralism, we invented the Global Fund, Gavi, the UN AIDS. In the year 2003, it was PEPFAR, DNDi, the Framework Convention on Tobacco Control, that was ratified by 168 countries. That's multilateralism at its very best. PEPFAR was a huge initiative, dispersing over $150 billion. And by the way, 2003 was the year that I met my wife, my now wife, so a very good year by all accounts. But what I really want to talk about in that decade was the World Trade Organization gets established in 95 with the TRIPS agreement. Now, the TRIPS agreement allowed for it's the trade-related aspect of intellectual property, and it governs patent law. Patent law gives originator companies 20 years of market exclusivity, and it was put in place in order to incentivize drug discovery. Okay, so they get this market exclusivity, which then is a financial incentive to develop drugs. Now, patent law is a double-edged sword, because on the one side, it incentivizes drug discovery. On the other side, it inhibits access to medicines. Okay, because there's patent law in place. And that was a big problem in developing countries. But the Doha Declaration in 2001, which is a legally binding interpretation of the TRIPS agreement, basically said that countries can circumvent patent law in the context of access to medicines for for public health reasons. And so it was between TRIPS and Doha that we were able to get 30 million people onto ARVs to date. I just want to fast forward here a little bit because I know we've got limited time. The next decade really was this very, very smart thinking, right? We had less money, there was less multilateralism, it wasn't these big grand gestures. But what happened in the next period of time was extremely clever. Unitate gets invented. Unitate focuses on market dynamics. So it's a small group of people, not a lot of money, but had a huge impact. Decreased the price of pediatric ARVs by 90%. Decreased the price of the cartridges that you use in Gene Experts by at least half, which meant that suddenly you could have point-of-care diagnosis of MDR-TB in remote parts of the world. And if you can diagnose people, you can treat people. And if you put people on treatment, you interrupt transmission. So it was a very, very powerful thing. They also financed, the next thing I want to talk about was the medicines patent pool. The MPP basically go into voluntary licensing agreements with the biopharmaceutical industry and then put them in a pool and sub-license them to generic manufacturers in poor countries. And that's the reason that we've got, for example, fixed-dose combination ARVs in poor countries, right? And fixed-dose combinations means one pill once a day, which means increased adherence to medical regimes, which means less drug resistance. So these were very small projects, relatively speaking, but incredibly impactful. And that's why I've called this era the era of thinking smart. I don't want to go into all of them because there's not time, but the ones that I'm not talking about are essentially public-private partnerships, PPPs, or advanced market commitments, innovative financing mechanisms, to basically encourage and incentivize early discovery of new drugs in the context of and particularly antimicrobials. So, why hasn't all of this worked? We're doing all of the right things, but the pipeline for new drugs seems to be relatively sparse. And the problem is that the time horizon to get these things over the line and to market just takes, it's longer than you can imagine. It's longer than what we need if we want to get this problem solved in the timeframes that we have. So coming to the rescue, and I was very pleased to see yesterday that there was a talk about artificial intelligence. There is new technology which I believe will be a game changer in this space. And there isn't time, once again, for me to talk about each of these. But what I do want to do is illustrate how incredibly impactful some of these can be. The example I want to use is DeepMind. DeepMind develops this AI called AlphaFold, which effectively can predict the shape of a protein based on the amino acids. Historically, we used to do that with X-ray crystallography, and it would take 4 years to predict or to figure out the shape of one protein. AlphaFold, in its first year of existence, could predict the shape of 200 million proteins. So it massively compressed the time horizon for development. MIT wanted to screen 100 million candidate molecules for antimicrobial potential. They screened 100 million proteins using AI in just 3 days. So these initiatives are going to massively and the examples I've got on the screen, which I can't go through, demonstrate how AI has been used at every stage of drug discovery. So my expectation is that these initiatives are going to compress the time frame for drug discovery, and the hope is that some of this will translate into meaningful, novel antimicrobials, which will be important. I think in summary, really what I want to get at is, I think we need 3 things plus 1, if I could summarize it like that. We need all 3 of these. We need to have, of course, this reliance on new technology. It's going to be a game changer, and we need to be excited about that. We need to carry on thinking smart, looking for things like Unitate and Medicines Patent Pool and other ways of ensuring access to medicines in poor countries. The thinking big has gone away. We're not doing anything like the scale of what we did in the 1990s, and I think we need to get back to that in the context of investment in initiatives to address antimicrobial resistance. And I enjoyed, one of the speakers was talking about the economic analysis that's been done. I think it was Sandra, was talking about the economic analysis that's been done. And as public health advocates, we need to be singing that song loud and clear, because we need politicians to get behind this. We need resources to get into it. One of the numbers that I read was that by 2050, the expectation was that this would cost the global economy in the region of $100 trillion. And I remember thinking to myself, well, how much is 100 trillion? Because it's very difficult to imagine the magnitude of a trillion. Our brains don't get around that. So I did a little bit of calculations just to sort of try and illustrate it. And I came up with this. 1 million seconds is about the beginning of the month. That's how big 1 million seconds is. 1 billion seconds was when I was at medical school. 1 trillion seconds is 30,000 years ago, when humans lived in caves with Neanderthal man and they were hunting mammoths. That's the difference between 1 billion and 1 trillion. It's unthinkably big. And I think that we need to make that point to politicians, that the opportunity cost, if we don't invest in antimicrobials and fighting AMR, we're in for a huge human loss, and of course that's the most important thing, but also an economic loss, which happens to be the things that politicians probably respond more to and we need to underline. I've got 2 seconds left, so I'll end right there. Thank you for your time. I appreciate it.
Thank you very much, Greg. So we have chosen to have the same question for all. So if for the next 12 months you would like to choose one step to be done for One Health, what would be?
I'd like to see advocacy to get political will behind this whole initiative, because that's really what's going to be needed. All the other things are being done. It's the political will, the investment, the money. That's the missing piece, and I really think that's what we need.
Yeah. And are you opportunistic regarding some novel antibiotics, novel molecule to be used, and they will be available for low-income countries where?
I am optimistic. I actually think with the new technology, with a lot of the organizations that I didn't really get a chance to talk about, there's a lot of really exciting, interesting initiatives that I think will bear fruit, and I do think we're going to see novel antimicrobials on the shelf in the not-too-distant future, and I also think that we're going to see them made available in low-income countries. But genuinely, this needs a big push. It needs the money. It needs the political support. Otherwise, the time frames will just be too long, and we'll end up in trouble.
Yeah, thank you. We had some questions. So the first questions that we received, it was from Viviane Bremer. should we not rather talk about planetary health instead? And I think all presentations gave the answer, and yes, to this one. Lila Mercuriali asked, what is being done to make sure that these discussions translate into engagement and actions at a local level? Who would like to make a comment, to give an answer?
I think, Mircea, it very much related to what Steph was talking about,
Yeah.
so working cross-agency, and that triggered the thought of, okay, that's great, but how do you bring it down to the local?
In fact, I think by acting, starting from yourself, what I mentioned, we shouldn't be paralyzed by the magnitude of the problem, but thinking where you are in your part of the organization, what can you do? It can be a unit, can be a department, can be cross-agency. Doesn't really matter. We're all part of the same chain. One Health beauty is it goes across, needs to go across tiers. One quick word to Craig. I loved your presentation, very daring. And you mentioned the Doha Declaration, you showed Nelson Mandela. I was looking at 2013 when your wife signed a marriage contract with Craig Martin. Very nice.
A milestone event.
Absolutely.
For Karen, after our collective experience with COVID-19, do you think we learned something from these pandemics for the future?
I do. I think we learned a lot about our blind spots. I think we learned a lot about testing our systems. But I also think that, you know, for me, the infodemic and learning a lot about how to manage those influences, I think has been important. You know, I think that we would, if we had predicted 15 years ago how our response would be globally, I think we would have thought about our collective will and our collective systems across the world for responding. I don't know that we would have predicted the sort of malign influences or just the distractions of the infodemic. So I do think that we're better prepared now to think about the way we move together. I think it's brought together interagency collaboration in a way and working across sectors in a much more urgent way, in a much more distinct way of breaking down those silos and learning that we have to work together to be prepared as global citizens.
An interesting question from Valentina Rizzi. Which are the possible indicators to monitor the progress of the implementation? Could we have some?
I could mention maybe the theory of change that has been developed by the quadripartite, the high-level experts group on One Health. They also allude to a number of indicators. I think it needs to be calibrated, obviously, to where you are. As any good intervention, you need to agree on the indicators before you start going. But again, like we see with the impact on measuring, for example, sustainability, we shouldn't be paralyzed until we don't know how to measure the impact. We should get started because there's a lot of venues where we are clear about it.
Greg, would you like?
I think it's exactly the right question to ask. I don't think we're going to be able to answer it in the time frame that we have.
Yes, we need 1 week.
But we really do
Maybe.
need to have real metrics that we watch, that we follow, that we take, and we need to set targets, and we need to hold ourselves accountable to those targets. But it's exactly the right question.
It's
properly behind that.
From Georgia Ladbury, what leadership qualities are particularly needed in order to help finally put the theory of One Health into practice?
I think that there are some real learnings from some of our identified gaps as we look at ourselves as communicators, as policymakers during this past pandemic. But I think that the soft skills of leadership, of compassion, of really trying to engage thought leaders at multiple levels, I think these are all some of the leadership skills that one agency is not the end all be all, but that there's a lot of value in cross-training a One Health workforce, and there's been a lot of effort to do that, so that you have ambassadors in all the countries where, where we've worked, where I think, many in this room have worked to really figure out ways to help them advocate in their sector.
From Daria Nikitin, what is the plan for this surveillance effort in the long term, and how can it be made sustainable? Again, it's about politics to be involved, to give resources, but what you can comment on this?
I'll just comment briefly because my day job is really surveillance. And a lot of what we think about in Ireland in terms of our surveillance program is how do we expand what we're currently doing into the One Health space. We very recently, we've kind of expanded our thinking from diseases into all hazards. And all hazards, of course, includes the environment, it includes the idea of One Health. I will tell you that it's not an easy leap to make. And I think all countries, including Ireland, and we need to work together, and I know the ECDC is facilitating a lot of these conversations that kind of get our thinking into kind of, past the way we've always worked. We've always kind of done the same old, same old. It's time to move surveillance into an all hazards, including One Health and environmental phase. So I don't have the answer to it, but I can tell you that we are thinking about it, and
yes.
it's front and center in front of us right now.
It's true. For Steph, regarding all the cooperation with different agencies, have you learned something very particular for your cross-agency activity during the pandemic and to be used from now?
Yes, I would say preparedness. Obviously, when the COVID hit, the agencies most affected were ECDC, maybe also the Medicines Agency, other agencies, myself, less so. Luckily, food wasn't a vehicle. When we met with a group, it's called the Ioan, which is a bigger group than the sister agencies that I mentioned, all the agencies providing scientific advice, like the work for OSHA for the human work labor and the Eurofund. We actually discovered how much we had been doing in isolation until that moment. We met a few months after the COVID started. So from there, we learned that we need to reach out earlier. And in fact, since then, we've organized a crisis preparedness exercise with the agencies, knowing what our roles are. And actually, we agreed on a framework for scientific cooperation during times of crisis, where we also would be quicker in, for example, sharing staff and sharing expertise across data.
In fact, somehow Sandra Galina told about this in her presentation. So, Jackie, if you can add some...
There are none to add. You have picked up on all the most relevant questions, so my work is done.
Thank you. So I gave the floor to Agnes to conclude. Thank you.
I made so many notes, and I tried to summarize them. The most important, most interesting parts I picked up. So the first message to me was that One Health should not become a silo. We should keep working together. We should keep brainstorming together. It's very important. Then the second message I took is that we should all raise awareness of One Health within our communities. We need to do what we can do from our own settings. And if we kind of reached the end of our creative ideas, let's just invite Madonna and do the job for us. And then the third point, it's very important next year, yeah. A message to the ESCAIDE Scientific Committee. So it's very important that AMR is not a silent pandemic. We should probably forget about this. It's a very loud and costly pandemic, and we need investment in One Health, and we need political awareness, which again goes back to collaboration across all sectors, but not only sectors, but across all types of partners. I really liked the arc from going from thinking big and then thinking smart, and then towards more innovative solutions. And in a way, it's also like hope that if we as humanity fail, we can always allow artificial intelligence to solve all our challenges. So I think these were the most interesting and thought-provoking points for me. I really like to thank you for all your interventions. I think it was a great session. I don't know if you have anything to add, Carmen, Mircea?
Just thanks.
Thanks.
Very good.
Thank you for joining us. And
room for a final thought? Is there room for a final thought?
yes, of course.
10 seconds.
10
10
seconds.
seconds final thought.
Since we agreed as countries to invest 3% of our GPD on research and investment to get ready for the future, One Health is needed to get ready for the future. Why not invest, I'm not saying 3%, but invest a significant part of our resources on One Health to be ready for the future?
On that note, will you join me in thanking our wonderful chairs, our wonderful panelists for a great session. Thank you so much. Steph, you said earlier we should all be ambassadors for One Health. You are certainly great ambassadors for it. So thank you very much indeed.
Thank you.
Thank you.